Infection after total knee replacement. Periprosthetic joint infection after total knee replacement can be a devastating complication. Early clinical suspicion and prompt recognition of the infected joint provide the best opportunity for successful treatment. However, diagnosing an infection is a challenging because many patients with an uninfected knee replacement experience pain, erythema, and other clinical symptoms that mimic an infection. Added to that, immediately after the replacement, all the markers of the infection will be raised even in a patient without infection. Determining diagnostic threshold for acute infection. A multi-center study evaluated diagnostic threshold for four laboratory tests commonly used to diagnose acute joint infection: serum C-reactive protein, erythrocyte sedimentation rate, synovial fluid white blood cell count, and percentage of polymorphonuclear neutrophils. Recent studies suggest that currently used threshold for these parameters lack sensitivity. Authors determined that optimum 90-day cutoff was 6130 cells for WBCs, 39.8 mg per liter for CRP, 39.5 mm per hour for ESR, and 79.5% for neutrophils. The optimum cutoff at 30 days for WBC count was 10,100 cells. These thresholds are lower than those formulated by the Musculoskeletal Infection Society. Routine diagnostic tests for periprosthetic joint infection demonstrate a high false negative rate and are influenced by the infecting organism. Although clinicians typically rely on all or some of those four tests as first line for testing joint infection. Review of 549 joint cases found high false negative rates with those tests, some of which were influenced by the infecting organism. Laboratory values in patients infected with the low virulence organisms or with the culture negative joint infections are often not elevated. The authors concluded that joint infection may be present despite normal laboratory values and that clinicians should not undervalue suspicions based on other findings. Culture negative periprosthetic joint infection. Culture negative periprosthetic joint infections remains a very perplexing problem. In a study of 219 patients, the prevalence of a suspected culture negative joint infection was 22%. Because every effort should be made to isolate infectious organisms prior to revision surgery, the authors suggest extending the incubation period for cultures and withholding the antibiotics prior to the obtaining culture specimens. Next generation sequencing techniques may also be useful in cases of culture negative joint infections. NGS has also revealed that some cases of apparently monomicrobial PGI have additional organisms that escape detection with traditional culture procedures. Fluorescence in situ hybridization for the diagnosis of periprosthetic joint infection. A separate study published in JBJS 2019 assessed whether fluorescence in situ hybridization of a formalin fixed and paraffin embedded periprosthetic tissues improved the diagnosis of joint infection. The authors found the technique feasible, rapid, and reliable, especially when combined with the clinical and histopathological classifications. Fish technique was also able to differentiate pathogenesis at the species level. And the recently introduced tool for the joint infection diagnosis is alpha defensin test. A study compared results from the rapid alpha defensin test with the MSIS criteria found a sensitivity for the rapid test of 94.3% and a specificity of 94.8%. The US FDA recently approved the rapid alpha defensin test to aid in diagnosis of periprosthetic joint infection. Combination tests in the diagnosis of a chronic periprosthetic joint infection. A systemic review published in JBJS American 2020 led to the development of a stepwise clinical decision-making tool for diagnosing chronic periprosthetic joint infection. The first step is a combination of serum CRP interleukin 6. If infection is suspected based on those studies, the authors recommended a joint aspiration along with a point of care leukocyte esterase test when a wet tap results. If joint aspiration needs a dry tap, the authors suggest relying on preoperative cultures of synovial tissue and histological analysis for diagnosis. Common pathogens. The most common pathogens in the periprosthetic infection are methicillin sensitive Staphylococcus aureus and methicillin resistant Staphylococcus aureus and coagulase negative Staphylococci. Patients colonized with these organisms are at increased risk for Staphylococcus infection following a total joint arthroplasty. Screening and nasal decolonization of Staphylococcus can potentially reduce the rates of surgical site infection. Screening and nasal decolonization of Staphylococcus aureus can potentially reduce the rates of staphylococcal surgical site infection after total hip and total knee replacement. Prevention. Prevention includes administering pre-operative antibiotics and managing host factors such as malnutrition, obesity, smoking, alcohol abuse, and urinary tract infections. If a morbidly obese patient has adequate nutrition, bariatric surgery should be considered. Smoking increases the risk of complications, including infections following both total hip and total knee replacement. Current smokers have an increased risk of wound complications, and both current and former smokers have an increased total complication risk following replacement. Any patient who has a painful and stiff knee after total knee replacement without a readily apparent cause should be evaluated for a periprosthetic joint infection. The widely accepted gold standard for treating joint infection after total knee replacement is a two-stage reimplantation. Risk of reinfection. There was one study in JBJ's American 2019 on this one. The long-term risk of reinfection and mechanical failure after two-stage treatment for joint infection are just now being investigated. A study evaluating 245 knees that underwent a two-stage exchange after a first-time periprosthetic infection found cumulative rates of reinfection of 4% at 1 year, 14% at 5 years, 16% at 10 years, 17% at 15 years. The mean in knee society score improved from 45 at PGI diagnosis to 76 at 10 years following reimplantation. The authors concluded that long-term reinfection rates were similar to short-term rates and that mechanical failure rates were lowest when bone loss was treated at the time of reimplantation. Mortality outcomes. The study was published in Journal of Arthroplasty 2018 on this mortality following periprosthetic joint infection. A database study investigating mortality outcomes following two-stage revision were analyzed in 20,719 patients. Researchers found a mean mortality rate of 14.4% over an average follow-up of 3.8 years. The average annual mortality rate increased by 3.13% per year after the first year. The authors suggest that these relatively high mortality rates should be mentioned during counseling and expectation setting with the patients. Choice between first one stage or two-stage revision. A decision analytics study was published in JB's 2019 to determine the optimal choice between the one stage and two-stage revision for managing chronic knee periprosthetic joint infection by estimating quality adjusted life years and cost. One analysis considered all pathogens and a second considered difficult to treat cases such as those involving methicillin resistant microbes. In both scenarios, a one stage revision produced greater health utility and was more cost effective than two stage revision. However, the author's analysis did not account for numerous potential co-founders. Debridement, antibiotics, and implant retention. A study was published in Journal of Arthroplasty 2019. They reported acceptable success rate. This is another option for treating periprosthetic joint infection is a debridement, antibiotics, and implant retention. A retrospective cohort study analyzed 58 patients who met Musculoskeletal Infection Society criteria. Polyethylene exchange was performed in patients with the modular tibial implants and two gentamicin loaded collagen plex were placed intra-articularly prior to closure. The mean duration of antibiotic treatment was 81 days, almost 3 months. Defining success as an infection-free knee at 2 years, authors found an overall success rate of 84% for patients treated with this procedure. Irrigation and debridement may be a less destructive periprosthetic joint infection intervention, but a retrospective study published in JBJS 2019 found that out of 199 total joint arthroplasties, found a 1-year failure rate of 37.7% after treatment of acute hematogenous joint infection with the debridement and retention of the implant. The authors found that host predictors of failure included prior revision surgery and higher Charlson comorbidity index. Specific comorbidities associated with the failure of this treatment included chronic obstructive pulmonary disease, diabetes, history of malignancy. Polymicrobial infection also had a worse prognosis. Persistent or a recurrent infection. Unfortunately, persistent or a recurrent infection may occur following a two-stage arthroplasty, and in such cases, patients are considered for a repeat two-stage exchange. A study of repeat two-stage procedures found 70% success rate after repeat exchange in uncompromised hosts, whereas type B hosts had a 50% success and the repeat exchange failed in both type C, extremely compromised patients. Revision failures. Arthrodesis is considered after such revision failures. In a recent study published in JBJS 2015, found arthrodesis with the intramedullary nail involving 26 patients had a persistent infection and 73% patients had a persistent pain. The authors concluded that intramedullary nailing in this setting should be regarded with a skepticism. PJ after total knee arthroplasty can be a catastrophic complication. Most successful treatment will come with a better understanding of which patients may benefit most from two-stage or one-stage exchange related to debridement, antibiotics, and implant retention.